Hi everyone, so we're back with chapter 3. This is part 1 of chapter 3. So let's get started. Chapter 3 covers the immune system. And first we're going to talk about the lymphoid tissues. So there are a couple of different kinds of lymphoid tissues. There's primary, which is located in the thymus and bone marrow. And then there's also secondary lymph tissues that can be found in the tonsils, adenoids, spleen, Peyer's patches, and the appendix as well. So a couple of notes here for you about the immune system. Your immune system is basically a major defense system, and it's responsible for a complex response to the invasion of the body by foreign substances. So anytime something that is not supposed to be in the body introduces itself to the body, then the immune system wakes up and they're like, hey, this isn't supposed to be here. So then they go to work to try to get it out of there. It's good to know that where these primary and secondary lymph tissue locations are, but the term that I want you to focus more on is the term here at the bottom, immunocompetence. And that's when homeostasis, I'm trying to get my pen up, sorry. So that's when homeostasis is maintained and the immune system reacts the way that it's supposed to, so it reacts correctly. So a couple of notes about that. If the immune system's response is inappropriate, meaning either it's too weak or it's too strong in its reaction, it will result in the disruption of homeostasis. And so we can't have that. We don't want that to happen either, because the whole point of being that the body is trying to achieve is this point of homeostasis, or this balance between the good things and the bad things that are in the body. Another note, the malfunction in the system of that either having too weak or too strong of a response is something called immunoincompetence. So that's different. Immunocompetence is when homeostasis is maintained and the immune system reacts correctly. If it does not maintain itself, homeostasis is not maintained and the immune system does not react correctly, then immunoincompetence is what we would call that. So for the immune system, again, there are a couple of different locations for those. You have the thymus up here in the chest area, and then you have the bone marrow, which you can see down here, and those are the primary locations, and then you have all these different secondary locations here. And so you have it in the spleen, you have Peyer's patches down here, the appendix, this guy, your little garbage can of your digestive system down here, adenoids, tonsils, lymph nodes, and all those places. All right, so immune system malfunctions. There are several different types of malfunctions that the immune system can have. These are pretty basic malfunctions. You have hyperactive responses, and those responses, that means that the immune system is excessive. The response is going to be excessive, and it's going to be triggered by specific allergens. So there's something very specific that triggers the immune system to react in a hyperactive manner. Then we have immunodeficiency disorders, and these are disorders in which the immune system is inadequate. So it's not sufficient. It's not adequate enough to fight off whatever it is that they need to fight off. You have autoimmune disorders, and those are the immune disorders that are where the immune response is overactive and is also misdirected against one's own tissues. And so the problem with autoimmune disorders is that the body, sometimes the immune system doesn't necessarily recognize that the body's tissues that are supposed to be there doing good for that person's body are actually there doing good, and they think that they are not. They think that they are invaders or they are foreign substances, and so that person's own immune system will attack their own tissues in error because they believe them to be foreign substances. And then last, there is also an immune system malfunction in which the immune system will launch an attack on a beneficial foreign tissue. For example, one of the things that the immune system will launch an attack on is the placement of an IUD, or an intrauterine device. And so when a woman has an IUD inserted in her uterus, the goal of the IUD usage is to prevent pregnancy, unwanted pregnancy, or accidental pregnancy, and the immune system recognized that, even though that was placed there intentionally, and it is useful for what the woman needs it to be useful for, the immune system doesn't care, and they don't get it. And so they think that this IUD that is now suddenly there, that isn't supposed to be there, is something that needs to be attacked. Same thing holds true also with transplanted organs sometimes. Sometimes transplanted organs are obviously beneficial, but they will be rejected and attacked by an immune system because they are foreign. So speaking of that, transplant rejection, we can have patients with organ, skin, and bone marrow transplants. There are a couple of different things I want you to know here. So before we go into the whole donor and recipient and how they're matched up and all that business, homografts is a graft of tissue that's between two genetically dissimilar individuals of the same species. So if you have a transplant from one human to another human who are not related, they're genetically dissimilar, then that would be a homograph. And those homografts, they're going to invariably evoke some level of transplant rejection. And that's going to end up being mediated by antibodies and a delayed cellular immune reaction. So basically what happens is that these next couple points here actually make this a little bit clearer. The donor and the recipient are going to be carefully matched up for blood type and immunologic characteristics. And then the recipient is going to be given anti-rejection drugs and steroids. So they are going to be given a bunch of medication to try to keep that person's immune system from attacking this new beneficial foreign tissue that's in that person's body. Okay, so there are three forms of rejection that you need to know about. The first is hyperacute. Hyperacute reactions are going to occur during the operation, so they occur during the transplant operation. If that happens, if there's a hyperacute reaction, the transplanted organ must be removed immediately to prevent inevitable complications leading to death. So up to and leading to death. So there will be complications. If there's a hyperacute reaction during the operation, there will be complications after surgery. So there is no sewing them up and hoping for the best. There will be dire consequences if that organ is not removed while still under. The second type is acute rejection, and that occurs most often within the first few weeks of transplantation, or sometimes later when anti-rejection drugs become ineffectual. So sometimes those anti-rejection drugs, while they're great to begin with, sometimes patients build up tolerance to them, or they no longer become effective, and so those drugs wear off and they aren't as effectual, and then the patient can develop an acute rejection. Then the last type of rejection is chronic rejection, and that's the type of rejection that evolves slowly over a period of months or years. Sometimes it takes years for people to reject an organ transplant. So, and if that's the case, then they are usually pestered by recurrent problems up until the final rejection. So just some notes there for you about the three different forms of rejection that I want you to be aware of. So let's talk a little bit about the orderly function of the immune system. So the immune system basically is activated when foreign substances enter the body. There's a whole process to that activation, but what you really need to know is that when something bad comes into your body, your immune system goes to bat for you. They got your back. They go and try to eliminate any threat that is posed to your health. So the immune system produces antibodies and in response to that specific antigen. So an antigen is a poison, or if you will, that is introduced into the body. It's a foreign substance that's introduced to the body, and then your immune system is going to go and make a bunch of antibodies to try to kill off that antigen. The way that it kills off that antigen is by forming something called an antigen-antibody complex, and that is where basically the antibodies fuse with the antigens and then make the antigens harmless. So there's a whole lot more to that, but for our purposes, you just need to be aware of what an antigen-antibody complex is. and that is what happens when antibodies attack antigens and make them harmless. Okay, so your immune system can differentiate between self and foreign molecules, except for when there is an autoimmune disease present. And that circumstance, as we'll discuss later on, that isn't always necessarily the case. So the last part here, natural killer cells, macrophages, and neutrophils are part of something called non-specific defense. So these natural killer cells kill virus-infected cells and tumor cells by secreting very specific toxins. The macrophages phagocytize, which means that they eat bacteria, viruses, and other foreign substances. And then lastly, polymorphonuclear neutrophils also eat or phagocytize bacteria. So these three types of cells here, natural killer cells, macrophages, neutrophils, these are more like your special ops types of guys in your immune system army. These are the guys that go out and kill things and blow things up and eat all of these bad bacteria. So let's talk about the development of immunity. Immunity development begins when the fetal liver produces stem cells. I'm sure you guys have all heard of stem cells. They are highly controversial, and we'll touch on that a little bit in the coming slides. But what you need to know for this slide is that you actually begin developing your immunity within utero. So the fetal liver is going to produce these stem cells. The bone marrow then takes over that production of stem cells after the baby is born. So some stem cells become T cells, and that's because some of these stem cells that migrate to the thymus gland in the chest. Remember a couple slides back I showed you where the thymus gland is? And that's where they're going to end up becoming or maturing into T cells. Sometimes they're also called T lymphocytes, so just a heads up there. These T cells then multiply and develop the capacity to combine with specific foreign antigens that are derived from viruses, from fungi, from tumors, and also from transplanted tissues. So these T cells are very, very important functions, or they play a very important function and role in your immune system. So definitely make sure you know what those guys do. Okay, so there are different types of T cells. So that's the overview for T cells. They go to the thymus, they become special forces T cells, but there are different types. So we have cytotoxic T cells, and they directly destroy virus-infected cells, tumor cells, and allograft cells by releasing certain toxins or inducing apoptosis. So what apoptosis is programmed destruction. Every time I see the word apoptosis, I think of Inspector Gadget, so that will tell my age. I'm probably much older than most of you. And there was a cartoon on when I was a kid that was Inspector Gadget, and in every single letter Inspector Gadget opened, it said, "This note will self-destruct," and then he very rarely ever escaped with any decent amount of time, in my childhood opinion, blowing up, because the letter always self-destructed before it was supposed to self-destruct. So every time I see the word apoptosis, I think of that self-destructing letter in Inspector Gadget, because that's what happens. These cytotoxic cells, they go out and they inject these virus and tumor and allograft cells with toxins, and if it doesn't kill them that way, they inject them with a strand that will cause those foreign cells to self-destruct and implode. All right, so the next type is helper T cells, and those stimulate the B cells to differentiate into plasma cells and to produce more antibodies. So they are also very, very important. So you've got your cytotoxic T cells, your helper T cells, which help boost up our antibody production. Then we have memory T cells, and those remain dormant until they're reactivated by the original antigen, allowing a rapid and more potent response years after the original exposure. Okay, so I'm sure you guys have already heard at some point in your adult life that you can't catch the same virus twice, or you can't catch the same disease twice. So this is why people think that is true, and it is for the most part. There are some exclusions to that general rule of thumb. However, for the most part, that is pretty true. So it's because you have these memory T cells. So when a foreign substance comes into your immune system, or comes into your body, your immune system launches its attack, sends its troops out to go and kill off this foreign substance. these memory T cells take a little bit of the DNA from that substance or a little bit of the code from that substance, and they remember it, which is why they're called memory T cells. And so that the next time that guy shows up, it doesn't take as long to kill him off. So the first time a virus is introduced into the body, you have a whole immune system response that the body has to go through. And so you'll be asymptomatic for a couple of days, then you'll start to develop the fever or the inflammation or the pus or the whatever nasty stuff is coming with whatever virus or bacteria or fungi or whatever it is you have. And then after that, the immune system will start to retreat because it will have sent out all of its troops to kill off this foreign substance, and then the immune system will start to retreat and relax a little bit. Well, when it's retreating and relaxing, the memory T cells, their part in that whole initial immune system response was to go back and take a snippet of that foreign substance so that they could remember it. So the next time that same substance shows up in the body, the immune system's like, hey, we've already kicked you out of here once, and we know you're bad news, so we're just going to do you in from the beginning. So they go and they wipe them out right away, usually before the patient is ever even symptomatic. So that's kind of awesome. If you're an immune system geek like I am, I think that's kind of awesome. Either way, even if you're not, you should be thankful that you have those because it helps keep you from being sick 24/7. Okay, so then the last type of T cells is suppressor T cells, and those inhibit, so they stop both B and T cell activities and moderate the immune response. So we need these suppressor T cells too. It's fantastic to have these cytotoxic T cells and these helper T cells and these memory T cells because they do so many great things for us. However, sometimes we can't let them be running all willy-nilly around the body and killing off everything that they think is supposed to be bad. So we have these suppressor T cells that kind of help keep the rest of these guys in check. So this is a nice little diagram. I kind of like it. I think it's in your book also. Let me get my pen here. So I think it's in your book also, but this is a nice little flow diagram of how stem cells are formed. And I told you that we would talk very briefly about why stem cells are so controversial, and this is why. So your stem cells start out undifferentiated, which means that basically these guys can grow up to be anything they want. They all start from these stem cells, okay? And so based on which way they go in the body, if they're if they come from the bone marrow, then they're going to take this route. They're going to be a pre-B cell, then they're going to turn to a B lymphoblast, and then they're going to be a B cell. And from a B cell, they're either going to be an antigen attacker or they're going to be a plasma cell. If they start in the thymus, then they're going to be a erythrocyte, and then turn into a T lymphoblast, and then they're going to be a T cell. And from a T cell, they're either going to attack antigens, those cancer cells, tumor cells, those type of viruses, or they're going to be a sensitized T cell. If that's the case, and they are a sensitized T cell, then they turn into one of these types of T cells that we were talking about earlier. So when you're thinking of stem cells, the reason why research with stem cells is so highly controversial is because the only place to get it is from the bone marrow. People don't willingly undergo bone marrow donations for science very often while they're alive. And then so the other place to get it is from fetal formations, which typically has to come from aborted fetuses, whether that be a selective abortion or a spontaneous abortion where the woman miscarried. That's where they get some of their stem cells. And so it's a big, huge controversy about using stem cells and how integrity and ethics play into that when it comes to retrieving those cells from fetal formations. So the other thing you need to know, that's the one side of stem cell production, but the other thing you need to know is why people are so hell-bent on using these stem cells to do research. And that is because they have figured out that these stem cells are baby stem cells. They can grow up to be whatever it is you need them to be. So if you have a massive tumor and all of your T cells have died off trying to fight this tumor and you don't have any T cells left to go and try to kill off this tumor, then you could theoretically use donor T cells and they could put them into your immune system, make them grow up to become these specialized or these sensitized T cells down here, which will help fight off the cancers. Or HIV helper Ts help kill HIV specifically. And so for HIV, the hope is that if stem cell research advances, then you can, or we will, as a medical community, be able to eventually cure HIV instead of only suppress and treat it. So it's definitely a two-sided coin, and people feel very strongly one way or the other on which they are pro or against when it comes to stem cell research. But I wanted to give you a little bit of background just so you kind of have an idea what the big huff is all about. So when we're talking about cell-mediated immunity, there's just a couple of things that you should note here. These bullets here that are listed, that cell-mediated immunity defends the body against viral and fungal infections. It mediates graft rejection and tumor cell destruction, and it also suppresses antibody-mediated responses to infection. Basically, what you need to know here is that the stem cells that develop into B cells end up producing antibody-mediated immunity, which is also known as humoral immunity. So you might see it that way sometimes, so it's good to know that that could be called either or, antibody-mediated immunity or humoral immunity. And that's the type of immunity that's going to protect the body against bacterial and viral infections, and then also reinfections. It helps protect against reinfections because once it has been activated by exposure to an antigen, the B cells are stimulated to proliferate or to reproduce and perform a clone of cells that, and form a clone of cells that respond to that specific antigen. We just talked about this a little bit ago with memory B cells. So some of these B cells become antibody-secreting plasma cells, and then others become memory B cells for a quick response if the target antigen presents itself again. Next, we have immunoglobulins, and immunoglobulins have 5 classes. There's IgM, IgG, IgA, IgD, and IgE. Now, that's how they are listed in most scientific manuals. I remember the names of the immunoglobulins because I end up actually switching these around, and I do, oops, sorry, let me fix that here. I make it G, A, M, E, and then D is the last one. So it ends up spelling, and I don't know if I can do it with my pen, but I can't write very well, but it ends up spelling gamed. This is horrible. Bear with me. There you go. So it's IgGA, IgGG, IgG, IgA, IgM, IgE, IgD. I got a little carried away with my IgGs there. Sorry about that. And that's how I remember the 5 classes of immunoglobulins. So just a little tip to help you out there. So usually all of these immunoglobulins are present during antigenic response. So if an antigen is present, then all of these immunoglobulins will show up to fight, although they are present in varying amounts depending on the stimulant. So an antigen-antibody complex, we talked about that a little bit ago, it activates the pathogen or the foreign object, the bad thing that's in the body, and stimulates phagocytosis. So it stimulates the destruction of or eating of that virus or tumor cell or whatever that foreign body is. Activation of complement system is going to involve proteins. So a couple of notes here for you. Active immunity is going to result when a person has had previous exposure to a disease or a pathogen, or when a person receives immunizations against a disease to stimulate the production of a specific antibody. I don't want to go too far into vaccinations here, but vaccinations and immunizations are very interesting scientifically. So if you ever are bored, I guess, one summer and want to spend some time researching something, research vaccinations and immunizations because they're pretty cool. Okay, passive immunity also bypasses the body's immune system to afford the benefit of immediate antibody availability, which is a really nice feature. So basically, it's this type of immunity, this passive immunity, is immediately available, which means that those antibodies can then go fight off infections immediately after they are passed through. So the antigen-antibody reaction, lastly here, initiates a series or a cascade of reactions, and that's going to activate the complement system. And fixing the complement and consequently permitting the destruction of pathogens by the process of phagocytosis or lysis, which is where they break it down, of the pathogen cell membrane. So just a couple of things there to remember about immunity, and we will keep moving. So the body is protected by active and passive immunity. Both types of immunity are very important. There's a couple of notes here for you. The active immunity results when a person has had previous exposure to a disease or pathogen, or they receive immunizations against a disease. So that's active. Make sure you know the difference between these two. Passive immunity bypasses the body's immune system response to afford the benefit of immediate antibody availability. So let's look at how those two work. You have active immunity, where the baby has contracted a disease naturally. So this, I think the example that they're trying to get with here is chickenpox. So, once you contract chickenpox, you go through the disease and you typically do not have a recurrence of chickenpox throughout your childhood. And that's because you have active natural immunity. You've contracted the disease and your memory cells remembered it, so they'll keep you from getting it again. You also have active artificial memory, and these are your vaccinations here. So they are active artificials. They receive a vaccination, and that causes your immune system to produce the memory cells to remember it so that you don't get it again. Although these are weakened versions, so you won't really ever have the disease initially. Basically, what they're doing with these vaccinations and this artificial active immunity is tricking the immune system into producing memory cells for a disease that it thinks you have, but what you really have is a weakened or attenuated version of that isn't enough to make you sick, but is enough to invoke an immune response. So then down at the bottom here, we have passive natural immunity, and that's what you receive from the mom while the baby is in utero. So you receive maternal antibodies through the placenta or after birth from breast milk. That's why there's such a big push for breastfeeding at least the first couple weeks, because it helps really boost the baby's immune system. And then lastly, we have artificial passive, and that is where patients receive an antiserum with antibodies that come from another host. So they are medicinally boosting up their immune system. All right. So now that we kind of have a general overview of how the immune system works and what it does and all of that business, let's get into the immunodeficiency diseases. So immunodeficiency diseases involve an increased susceptibility to bacterial infections, typically resulting from a B cell deficiency. They also have an increased susceptibility to viral, fungal, and protozoan infections, usually from a T cell deficiency. So remember we talked about B cells and T cells, and so you kind of know the difference between those now, and you can see how each of those different types of cells plays out in an immune deficiency disease. So some of the conditions are genetic, and some of them are, because they're genetic, present at birth. A couple of things I want you to know. So although the deficiency may be in either the humoral, which is the antibody related, or the cell-mediated responses, the consequences are going to end up being pretty similar. The individual does not have the capability to dispose of foreign and harmful substances. So no matter which deficiency it is that they have, that is to say that they will end up ultimately not being able to fight off whatever it is that they're trying to fight off. So acquired immunoincompetence may result from a bacterial or viral insult to the body, malnutrition, or exposure to radiation or certain drugs. So just kind of remember that. There's a little tidbit for you there, that even though some of these things are genetic and present at birth, other ones, which is acquired, so they pick that up at some point throughout their life from exposure, acquired immunoincompetence, meaning that the immune system isn't performing correctly, can result from bacterial or viral insult to the body, malnutrition, or exposure to radiation or certain drugs. Let's look at some conditions and infections that show up frequently in people that have been diagnosed with AIDS. The first is Kaposi Sarcoma and lymphoma. And Kaposi Sarcoma is an aggressive malignancy of the blood vessels that appears as purple or blue patches on the body. So it almost looks like they have lesions, and they're these purple or bluish lesions. And there's some pictures, I think, in the following slides, so we'll look at those in just a moment. The next one is pneumocystitis, carni pneumonia, and tuberculosis. And P. carni pneumonia is a lung infection that can progress to be life-threatening. Unfortunately, for people who are immunocompromised with AIDS, pneumonia is actually what typically ends up killing them. Not so much the virus itself, but it is a secondary infection such as this P. carni pneumonia. Tuberculosis is also a bacterial infection of the lungs or other organs. Then we have herpes simplex and herpes zoster. So herpes simplex consists of painful blister-like lesions of the mouth, the genitalia, the anus, and those are all caused by the herpes virus. And then we have herpes zoster, which is more commonly known as shingles, and that's characterized by clusters of red blister-like skin lesions that are distributed along the distribution of an inflamed nerve. So basically what happens, shingles typically are one-sided, and they will follow the entire nerve path down that one side of the body. So it's pretty unique to see somebody with shingles, because you know that it's probably shingles just based on the distribution pattern of those lesions. Okay, the next one is Candida albicans. C. albicans causes a fungal infection of the mucous membranes of the mouth, the genitalia, or the skin. Then you have toxoplasmosis, and that's an infection caused by protozoan intracellular parasites. And then lastly, we have a variety of neurologic complications, and these can include things like inflammation of nerves, neuropathy, so pain, neoplasms, and then something that's known as AIDS dementia complex. Right. So here's the picture, as promised, of Kaposi sarcoma, and you can kind of see the different colors of blue and black lesions there on this person's. It appears to be a foot. And then we have primary perineal herpes. For those of you who do not know where the perineal is, or the perineal area, it is the area between the genitals and the anus. So this, from the looks of it, is probably a woman who has perineal herpes, and so this location will be between her vaginal opening and her anal opening. This, I just want to point out here with the different colors, you can see that these are open and red, and then these lesions here have a bluish tint to them, and that's because for these purposes, for demonstration purposes, they have been stained with this stuff called methylene blue stain, and that sometimes allows physicians to visualize areas and the perimeter of those lesions a little bit better. Okay, so this is hairy leukoplakia on the tongue. That's fun. And now we're on to more on AIDS itself. So AIDS is a progressive impairment of the immune system caused by HIV, the human immunodeficiency virus. Most people know that HIV causes AIDS, but HIV is actually a very small portion of the challenges that are associated with AIDS. However, it's a very important one because it's what kickstarts everything else. So AIDS can affect many organ systems. It's often life-threatening. People, though, may remain healthy for years during latent periods. So what happens with this AIDS virus? It's a tricky guy, this HIV virus and AIDS. They this virus, this HIV virus, can lay dormant for years. That's why they tell you after you've had exposed or risky sex or a needle exposure or anything like that, you want to keep getting tested every 6 months for like 5-10 years afterwards, because you can have the virus and it can take up to a year to show positive on a blood test. But then even when you have the virus, you can feel fine and be going along because this virus is just hanging out in your body, sleeping. It's just chilling and not really doing a whole lot. It's going to hang out there. And then all of a sudden, you'll get some type of infection and it will wake it up. And when it wakes up, it will wake up with a vengeance. And that's when people will start to experience the actual symptoms of AIDS. Okay, so, or excuse me, it could be HIV or AIDS. There's a very distinct difference between the two, and I'll tell you about that soon. Okay, so the patient may also experience a flu-like illness with a sore throat, fever, and body aches, lymphadenopathy, weight loss, fatigue, diarrhea, night sweats. All of that is common with AIDS. Often in the later stage, encephalopathy and malignancy lead to dementia and death. An individual who complains of weight loss, fatigue, swollen glands, night sweats, persistent flu-like syndromes, those people should be referred to an appointment with a physician for a medical evaluation as soon as possible. If it's persistent and it's not going away, then it's definitely worth checking out and making sure that it's not HIV or AIDS. When an individual reports known HIV exposure through unprotected sexual contact or puncture with a contaminated needle, it's important and pertinent to their health that we take immediate medical care and arrange immediate medical care for them. So let's look at some of the pathologic changes that are associated with AIDS. We have meningitis, encephalitis, and AIDS dementia within the brain and central nervous system. Mouth has herpes and thrush. Lung can have pneumonia. Lymph nodes can have lymphadenopathy. You can have tumors in the lymphoma here in the lymph nodes also, which is the lymph cancer. AIDS, nephropathy, which is a disease of the kidneys. You have Kaposi Sarcoma, all kinds of stuff here. Malabsorptive small intestine. There are many, many changes that the body goes through once they have developed AIDS that are not good. None of them are good. And many of them are very difficult for patients to sustain themselves through. So I think this diagram is also in your textbook, and you can check it out. I really like this graphic because it does a good job at pointing out all of the different things that are associated with AIDS. So we're going to talk a little bit about the etiology of AIDS. AIDS is caused by HIV virus, human immunodeficiency virus, and it's either type 1 or type 2. HIV attacks the helper T lymphocytes. So a couple of slides ago, I told you that there was a distinct difference between HIV and AIDS, and this is the difference. So HIV attacks these helper T lymphocytes. And basically, once your T cells and your CD4 count gets below, I think it's T cells below 200, if I remember correctly, or maybe it's your CD4 count below 200. But when your T lymphocytes get down to a certain critical level, you are declared to have AIDS. Instead of being HIV positive, you then become AIDS. And that doesn't change. Even if with medication, you're able to get those T lymphocyte counts up again, those killer T cells up again over 200, it doesn't matter. Once you hit that threshold and you dip below 200, you will have what is considered to be full-blown AIDS from that point forward. So HIV directly affects the nervous system. It's spread most by direct contact with blood or with semen. And then sexual contact, it makes sense then, is the primary transmission. However, HIV can also be spread by blood or through blood products. So back up to the top here when I was talking about those T lymphocytes, the destruction of T cells and then the proliferation of HIV leave the body defenseless against infection and against cancer cells and all of those horrible types of cells that can come into the body. by reducing cell-mediated immunity. So a couple of facts here for you. According to the CDC, which is the Centers for Disease Control and Prevention, most sexually transmitted cases of HIV in the United States occur through men having sex with other men. Worldwide, though, heterosexual transmission is the primary mode of transmission of HIV. So there was a big, huge thing when HIV and AIDS first came out in the 80s, late 80s, early 90s, about gay men being the proprietors for this whole entire deadly viral movement. And then after some time and some more research and more cases have popped up, we have discovered that that's not necessarily the case. That may be the primary means of transmission in the United States. However, worldwide, it is not. And that's because AIDS runs rampant in several other impoverished nations, and heterosexual sex is how that continues and propagates itself there. So AIDS transmission can also be transmitted through blood and blood products, like we said, but the infants of infected mothers can contract the disease in utero. So while the baby is still being cooked, through the placenta, it can also contract the disease through the birth process and then also from breast milk. A common lab screening that we use to detect the presence of HIV bodies in the blood enzyme or in the blood is called enzyme-linked immunosorbent assay, which is an ELISA test. So sometimes you'll see that it's ELISA, and that's the commonly used screening test for HIV. So treatment. Unfortunately, no cure exists for AIDS. That's pretty well known. There are periodic measurements taken of the number of CD4 T cells and the amount of HIV RNA. Numbers can also be used to help determine when to begin HAART, which is highly active antiretroviral therapy. So what they do, these first couple points here, what they do is they take a look at both of these markers because they help determine the disease progression from the initial infection with HIV all the way up to the development of AIDS. And then once they look at these numbers and these numbers get to a certain count, like I said, I believe it's 200, then it can be determined whether or not it's a good time to start that antiretroviral therapy. And that retroviral therapy consists of a three-drug combination: 2 nucleoside reductase inhibitors, and then either a non-nucleoside reductase inhibitor or a protease inhibitor. So this is the thing. I don't really care that you know which drugs are associated with it, but you do need to know that these drugs are associated with many, many toxicities. They are very toxic to the patient. And so we don't put just anybody on these medications. They have to have something, AIDS or something very similar, another viral infection very similar. So although AIDS is ultimately a fatal disease, the good news is that the number of Americans dying of AIDS each year continues to drop. So that's a fantastic thing. Healthcare practitioners should follow infection control procedures because all bodily fluids and blood from any patient needs to be handled with extreme care, as if the patient were known to be infected with HIV. When I was drawing blood years and years ago, I worked as a phlebotomist in a hospital for a long, long time. And that was one of our training placards, actually, was to assume that everybody has HIV. And they did that not to make us believe that the entire population that we were treating or working with had HIV, but because we can't tell. We don't always know. Sometimes the patients themselves don't even know that they have it. So we use universal precautions in order to treat every patient like they have HIV, and also to treat ourselves like we have HIV and we're protecting that patient from. So it's not just us protecting ourselves from patients, it's us protecting patients from us as well, because they don't know what we have either. Okay, last little point here that I want to make is that because HIV is transmitted directly from human to human, prevention measures, like I just mentioned, relate to avoiding risk factors for sexually transmitted diseases and practicing infection control through the use of universal precautions. So those universal precautions are there for a reason. They are universal. They are not to be digressed from in any fashion. You are to assume that everybody is infectious and assume that that you are infectious to every patient. So that way, you know, it's a constant reminder to continue to use those universal precautions. So infection control and universal precautions. Let's talk about that for just a little bit. The first thing you want to do is make sure that you wash hands frequently and report accidental needle sticks. Believe me, I speak from experience when I tell you, you want to report accidental needle sticks. I stuck myself with a known Hep C positive needle once. The guy jumped and he scared the crap out of me, and I stuck my finger with his dirty needle. I knew he had Hep C because I had drawn his blood for a long time, many months. I have been drawing his Hep C levels. So I you know, freaked out because I had only been on that job for, you know, a year and a half or so. I didn't want to have a needle stick, but on the other hand, I also didn't want to run the risk of becoming sick and not being able to take care of my children. So I reported it, and right away they sent me over, put me on, you know, did a bunch of blood work, and ended up, long story short, putting me on a bunch of antiviral medications. So it's good to report those. Do not hide needle sticks. Everybody has accidents. Hopefully no one does, but if you do, it's to be expected. It kind of goes with the territory when you're using needles all day long. Okay, you want to wear personal protective equipment and use caution with lab specimens. Dispose of contaminated sharps and properly dispose of linens, and then always use clean mouthpieces and resuscitation bags. A couple other things I want you to know here on this slide. You should make sure that you're using proper decontamination techniques. I mean, you know, you're supposed to decontaminate, but you want to make sure that you are using proper techniques and solution ratios to achieve that decontamination. And then also, if blood is ever spilled, you want to absorb that spill with paper towels, and then you're going to clean the area with soap and water, and then follow that up by disinfection of the area with a solution of household bleach that is 1 part bleach to 10 parts water. Then that should help keep most viruses at bay and keep anybody from picking up any unnecessary bugs. Common variable immunodeficiency is CVID. That is an acquired B cell deficiency that results in decreased antibody production or function. So it's a B cell deficiency, which means that there's not enough antibodies, that causes not enough antibodies to be produced. Patients may have a history of chronic or recurrent infections, GI diseases, including diarrhea, abdominal pain, weight loss, things like lymphadenopathy, splenomegaly, so an enlarged spleen, an enlarged liver, or hepatomegaly. Those are often observed with CVID also. It's also involved with chronic lung disease and granulomatosis diseases. Those are common. CVID is associated with an increased frequency of autoimmune disorders, also such as autoimmune hemolytic anemia or immune thrombocytopenia. And then also people have a susceptibility to opportunistic and viral infections, and malignancies escalate. And that's because those B cells aren't there to produce antibodies to fight off those infections and malignancies. So just one side note here, if a kid or a teenager, a child or a teenager is susceptible to frequent infection, then we recommend that an appointment be made with their pediatrician or their healthcare provider to discuss options, so that we can get them referred to the appropriate specialties or whatever it is, because we want to make sure that they don't have this CVID. So if you have a kid or you know of a child that has frequent recurrent infections, or they have these weird GI things going on, or lung issues, or any of this stuff, you want to make sure that we get them to the right place. So definitely suggest that or help facilitate an appointment with them and their primary care provider. So the exact cause of CVID is unknown. It's thought that genetic defects lead to immune system dysregulation and a failure of B cell differentiation. Regular immunoglobulin replacement decreases the number of infections, antibiotic usage, and hospitalizations. That's a bummer though, because then they have to go through transfusions to have these immunoglobulins replaced. So CVID has two peaks of incidence, one that usually happens between the ages of 18 and 25 years, and then a smaller peak that happens between the ages of 1 and 5 years. And what happens is the number of circulating B cells may look normal, but the ability of those B cells to produce types of immunoglobulins is going to be reduced. They may have an okay number of immunoglobulins, or excuse me, an okay number of B cells, but those B cells aren't pumping out those immunoglobulins, that GAMED that we talked about a few slides ago. They're not making enough of those to fight off infections. So if we see a kid that has repeated or chronic infections, then that should lead to further investigation of those immunoglobulin levels to make sure that they have sufficient T cell quantities also. If we know that a patient has CVID, then we want to make sure we monitor them closely, because that means that they're going to be at an increased risk for development of autoimmune diseases and different types of lymphomas. Also, the use of immunoglobulin has improved the prognosis, and patients often succumb to chronic lung disease or malignancies more often than they do actual CVID. So it's, again, a secondary infection or a secondary disease process to CVID, which actually becomes fatal for them. So one of the variables for CVID is immunoglobulin A deficiency. And the majority of these patients are going to be asymptomatic, so they're going to have no symptoms at all. Those who do experience symptoms have recurrent sinopulmonary infections, GI infections, and or autoimmune diseases. Anaphylactic reactions to blood transfusions may occur, and because of that, it's very important that we monitor patients closely whenever we give them blood products, because we obviously don't want them to go into anaphylaxis. Also, there's screening for anti-IgA antibodies that can help us identify those who who may be at risk for an adverse reaction to the transfusion of AGA. Immunoglobulin A deficiency is a failure of B cells to produce adequate levels of IgA is the most common defect. In most cases, there aren't really many significant medical problems that are expected with this type of deficiency, and the prognosis is pretty good, so that's encouraging. Unfortunately, though, there is no prevention known, so if it does happen to be a rare case where it's problematic for the patient, then there's not a whole lot that we can do to prevent it from getting worse. Treatment of selective IgA deficiency is geared towards infection management primarily. We're going to give prophylactic antibiotics. So those are kind of preemptive antibiotics. We give them in advance of what we suspect will something that we may suspect will turn into an infection, or to prevent them from getting an infection altogether, especially if they're going to be in an immunocompromised situation, such as a surgical procedure or something like that, dental procedure. Sometimes they'll give antibiotics in advance to help keep infections at bay. Intravenous immune globulin with low concentrations of IgA may also be tried. And then patients should be monitored for development of autoimmune disease or progression to CVID. So let's look at X-linked Agammaglobulinemia. This happens when an infant has absent or near absent tonsils and adenoids. X-linked Agammaglobulinemia is a condition that's usually characterized by the near absence of serum immunoglobulins and an increased susceptibility to infection. Lymphadenopathy and splenomegaly are missing. They may have recurrent severe bacterial infections in an infant that would signal the need for in-depth medical investigation to determine the possible underlying causes. So this infant has basically no tonsils and adenoids. They have recurrent infections. They could have lymphadenopathy and splenomegaly, and so, or that would be missing, which would be typical in other immunoglobulin errors. And so that would warrant and investigation by the physician or pediatrician or whoever to determine the underlying cause and make sure they don't have this X-linked Agammaglobulinemia. It's an infection with enteroviruses, also are common with this type of disorder. It typically only affects males, and the defect has been found in the Bruton tyrosine kinase, or the BTK gene. All 5 immunoglobulin classes are usually absent in this disorder, along with the absence of circulating B cells and the presence of normal numbers of circulating T cells also. Most individuals will present with symptoms by the age of 5 and almost have all of the symptoms associated with X-linked Agammaglobulinemia, that's a mouthful, by the age of 5. So the clinical findings, along with a thorough history, including family history of relatives who died of severe infections, would be suggestive of the possibility of the patient having X-linked Agammaglobulinemia. Treatment is geared at improving immune defenses. So we could offer the patient intravenous infusions or subcutaneous administrations of immune globulin every 2 to 4 weeks. We also could offer appropriate antibiotics when necessary and administer those, and then killed vaccines are also administered. So a little note here on this bottom one, killed vaccines. It's super important that these patients are never immunized with live virus vaccines, nor should corticosteroids or immunosuppressive drugs be administered to these people. It can kill them. It can literally kill these kids. No methods of prevention, unfortunately, are known for this disorder, although parents of the affected children are encouraged to seek genetic counseling regarding future pregnancies. So if they're concerned, if they discover that their child has X-linked Agammaglobulinemia and they're concerned about forthcoming children having this sort of disorder, we can refer them to a genetic counselor to establish the possibility of that. SCID is severe combined immunodeficiency. This is pretty serious stuff. It says severe right in the name of the disorder, so you know this is pretty heavy stuff. It is T cell signaling needed for B cells to produce antibody. B and T cell immunity is absent. So you have no antibodies and you have no special ops guys in your immune system army. That's bad news. So basically, let me kind of break this down a little bit. SCID is actually a group of disorders that result from a disturbance in the development and the function of T cells with or without B cells. It usually manifests as severe recurrent infections with bacteria, viruses, fungi, and protozoa. More commonly, you'll see pneumocystitis, pneumonia, and persistent mucocutaneous candidiasis also. The history of pneumonia in the first weeks of life, so if you have a baby that has a history of pneumonia right off the bat, followed by frequent severe infections in the young infant, are typically indicative of underlying conditions that would definitely need a complete medical evaluation to rule SCID out. So just kind of keep that in mind there. So there are 2 types, X-linked and autosomal recessive. Both of them are due to genetic mutations that lead to defects in the stem cell differentiation into B cells and T cells. So basically what happens is, way back at the beginning of this section when we were talking about the different ways that stem cells develop into B or T cells, there was that little diagram I told you I liked, and it showed you how those cells graduate from stem cells all the way up to whatever it is their grown-up jobs will be. So in this disorder, in this group of disorders rather, these stem cells have trouble differentiating. So they don't actually ever, they start off as stem cells and then they end up being something else. They don't ever actually turn into B cells or T cells. Or if they do, they have some type of mutation. Bone marrow transplantation is the only curative treatment that is a very extensive, painful process to go through. There is some gene therapy that's being investigated as a possible solution or treatment program for future, but for right now, bone marrow transplant is about all we've got. It's not preventable. I'm looking at my notes here, sorry. So unless the underlying gene defect is corrected, these children will definitely die of overwhelming infection before the age of 1 year old. So that's the big problem with this. Like I said, it's severe stuff. It's bad. It is hell for parents. It is not fun for the kids. It's not fun for anybody. So we definitely want to be on the lookout for the possibility of this being a concern and get them directed to the appropriate medical treatment as quickly as possible. Okay, so we'll pick back up here with part 2 next.